Hello, everyone. Please let me know when I can start. Okay. Okay, I just hear that I can start. Welcome, everybody. I'm very happy to be here. Very pleased that you are with this big amount of attendees. I will start sharing my screen and I will introduce myself, and hopefully we will have a very nice webinar where you can learn a lot about our PAT technology. So here we go. Please let me know if you can see the screen. Can you see the screen? Sorry. Yes, sir. Could you please text me if you can see the screen? Okay, thank you. Okay, perfect. Okay, thank you. So welcome everybody in the sleep apnea diagnosis webinar. My name is Margret Verspaandonk. Sorry. Margret Verspaandonk. I'm based in the Netherlands. I work for Zol Itamar Medical since 2019 as Director of Clinical Affairs. And since this year, I started as Area Business Director for the region EMEA. I'm also an ESRS certified somnologist technologist, so I have a lot of experience in scoring, interpretation of clinical and also home PSGs and polygraphies, EEGs in the department in sleep and epilepsy in the tertiary center in the Netherlands. Also board member of the ESST and a member of the examination committee of the ESRS. So a lot of experience in sleep. And since 2019, I'm more and more involved also in scoring watchpad tests and go into the raw data and do the interpretation of all the signals. So welcome, everyone. I declare I'm working as a full-time employee for Zol Itamar Medical, as I already mentioned. I want to take you through the program. So the welcome and the introduction we already had. We will start with the basic of sleep diagnostics to give you an overview of all the diagnostics we have and talk a bit about the sleep physiology. Then we go to understanding of the PAT technology. So I will tell you about how is the watchpad working? How can we do the interpretation of the PAT technology? How can you use it in your clinical settings, in your diagnostic settings, in your sleep center? And when it's how you can use it and what's the best way to use it actually. Then we go over some reports, the interpretation of the automatic generated reports, how we can do the interpretation of the PAT recording and how we start always with the report. And I'll give you some examples. We also have some advanced cases at the end of this webinar. And of course, at the end, we have also time for questions and answers, and we will close this session. I also want to mention, if you have questions in between, maybe you can put it in the chat. So I will pause during my presentation on some regular basis to see if there are any questions, and feel free to ask if something is not clear or if you want to know something else or you want to talk about something. Okay, the learning objective for today, so an overview of the different sleep diagnostics, also a look at deeper look at the sleep physiology, understanding of the watchpad technology, reading, interpretation of the watchpad report. We discuss the manual scoring guidelines, and we see some advanced cases in the watchpad. And I heard from the organization that we have different audience with a lot of people from the sleep medicine field. So, and also we have beginners who never heard about the watchpad and sleep diagnostics in general, and others who are really into the diagnostic of sleep. So it will be a basic introduction and a broad introduction. So we are talking about sleep, and sleep actually is very important. And if you sleep well, we never realize actually what we never realize really what sleep is for, because when you go to bed and you sleep and you wake up in the morning and you have never problems to sleep, it's okay, you know, it belongs to your daily routine, and there are no problems with it, so you never really think about it. But sleep is a very, very important process, and everyone and everything needs sleep. And if sleep doesn't serve some vital function, it's the biggest mistake evolution ever made, because actually 1/3 of our life we sleep. So it must be very important. Also very important to remember for us as adults, actually, is that sleep is one of the 3 pillars of good health, along with exercise and diet. So it's important to realize that when you have patients and they have problems with sleeping, or they have sleep disorders, they can really have a lot of comorbidities, which are also related to those sleep disorders. And it's very important to realize that bad sleep can make you really sick. Actually, it can make you fat, it can make you sad, you can get depressions of it. And at the end, if you don't sleep at all, it may definitely kill you. So it's important to realize how important sleep is in the medicine field. Okay, when we talk about sleep, as I already mentioned, like 25 to 30% of our life, we are sleeping. Yeah, so it must be a very important thing. Why do we sleep? We sleep because our body needs rest. When we are tired, we need to lay down to rest the body, but also the brain rest is very important. Actually, during sleep, the brain, there is a sort of a cleaning process in the brain. So including beta, amyloid, and other trash will be cleaned up in the brain. And it's also important for memory consolidation. So it's important for us to sleep well, and to sleep also a certain amount of hours. But actually, it depends per person how many time we really need sleep. Who is sleeping? Actually, everyone and anything is sleeping. Everything what you see has a process. Also, when we look at flowers, or we look at trees, or we look at everything around us, a living thing is sleeping and has a cyclic process. Here can we see actually how we build up the willing to sleep, actually, the sleep pressure during the daytime. So when you wake up, actually, when you wake up, there is a low sleep load, right? So when you go during daytime and the hours and hours go by, when we are in the evening, yes, we have an increased sleep pressure. So we build up a certain sleep pressure, sleep load. And this sleep load is also necessary for us to fall asleep. Yes, and when we fall asleep, we can see that the sleep load decreases again. Yes, and then in the morning it increases again. So it's a cyclic process. How much sleep do we need? And like I already mentioned just before, that it really depends per person. But what we say actually, that adults need around 6 to 9 hours of sleep. But when we do sleep diagnostics and sleep tests, and we look in the sleep medicine field, it's really helpful to realize the age of the patient, because when you are looking at very young children and babies, for example, of course, they sleep a lot. They have a very long sleep time, 13 to 16 hours during the day. Also a lot of deep sleep and a lot of REM sleep, rapid eye movements. Children, of course, also depending their age, the sleep time goes down when you are getting older, but children need 8 to 12 hours sleep. And what we see is that the light sleep increases actually compared to the infants, and the deep sleep and rapid eye movement goes down. And the older we get, actually, the light sleep stages, so stage 1 and stage 2, increase, and the deep and the rapid eye movement, and especially the deep sleep, goes down, and the rapid eye movement sleep also goes down through adults and elderly. So what we can see is also that sleep is developing also during our age. And it's also, of course, dependent from what we are doing during daytime, because you can imagine when you have a very stressful day and you have a lot of things in your mind and on your mind, it's more difficult to fall asleep and to have a good night's sleep than when you are very relaxed and you had physical activities, you're really tired. You have most of the time a better night's sleep with more sleep time, less fragmented than what you're doing than when you are very stressful and you have a lot of things on your mind. So it's also important to realize that sleep is different in each person. Yes, but it can also differ a bit per night, because it's really depending on how you feel, what you're doing during daytime, etc., etc. That's why it's important when people have suffer from insomnia or bad sleep or whatever, that you really take a deep look into their sleep hygiene, actually, and their sleep habits, to see if something is going on there, because it's important to know also what patients are doing during daytime, because you really need to prepare yourself for a good night's sleep. So how does the sleep look like? Here I show you, actually it's called a hypnogram, and a hypnogram is actually a schematic overview of how we sleep in one night. And when we take, for example, 8 hours, we can see that sleep is a cyclic process. And what we see here in this hypnogram is the red blocks are the REM sleep. So it's actually the rapid eye movements, the dream sleep. And we can also see the periods when the patient is in light sleep and in deep sleep. And what we see that during the night, we see every time the REM sleep pops up. Yes. And in the beginning, it are shorter periods. And at the second part of the night, there are broader periods of REM sleep. In the beginning of the night, there's more deep sleep. And at the end of the night, there's less deep sleep. So what they say actually is that deep sleep is more important for your physical recovery, yes, and the REM sleep is more for your emotional recovery, yes. But there are still a lot of things what we don't know about sleep and about the sleep stages, and actually what for example the function of the light sleep, for example, we don't know. There are a lot of things that we don't know about sleep yet, but also a lot of things we do know already. So this is actually the schematic process of how to see how people sleep, and it's very important also that you can see actually in one glance, you can see if a patient has a good night's sleep, if they wake up a lot, if they have a very fragmented sleep, and if all the sleep stages are there. So first, you start with wake, because you have to be awake to fall asleep. Then you start in light sleep, a few minutes. Most of the time is like in the beginning, 10 minutes light sleep. Then you go to deep sleep. And then you have your first REM period. And most of the time, when it's a normal sleep, we say between the 60 and 90 minutes, it's the first cycle of sleep. So that's where the first REM period starts. And then we have the next cycle again, light sleep, deep sleep, REM sleep. That's another 60 to 90 minutes. And then another 60 to 90 minutes also ended by REM sleep. So each cycle is ended by REM sleep. Like I already mentioned, it's very depending per person how many hours sleep you need. And they say like Albert Einstein, he slept like 10 hours per night. But Leonardo da Vinci, for example, he slept only every 2 hours. He slept like 20 minutes. So it's also depending per person, but it's important that you get your amount of sleep. Yes, and the one sleep has enough with 5-6 hours sleep, and the other one needs really 9 to 10 hours. Okay. When we talk about sleep, we talk about sleep structure. And like I just mentioned, that we have different sleep stages. And we have stage 1 and stage 2, which are the light sleep stages. We have stage 3 is the deep sleep stage. And we have stage R, and it's the REM sleep. And actually, the light sleep and the deep sleep are the non-REM stages, and REM is, of course, is a REM stage. And what do we see? We see different processes in the body and in the brain activity during the different sleep stages. So when a patient turns from wake into light sleep, it goes from wake to stage N1. And in N1, we see that the patient starts with slow eye movement, the brain activity in the EEG slows down, there is muscle relaxation, but it's very easy to wake up. So when you are in stage N1, is that you just fall asleep, and you have, when you hear a sound outside or somebody is moving next to you or whatever, you can easily wake up. Yeah. When you go to the next stage, is stage N2, also light sleep, but things are a bit changing. You go to a bit deeper sleep, and you have a decrease of your body temperature, and you have a decrease of your mean heart rate. Muscle relaxation and tension is a bit mixed, because still there, when you have arousals, you can hear, you can get waked up from sounds outside. And your brain activity, your EEG shows K complexes and sleep spindles. So this is a different kind of EEG. In N1, we saw some slowing down, more theta activity. Stage 2 is specific brain activity like K complexes and sleep spindles. Stage 2 is actually the biggest amount of your total sleep time. You are in stage 2. Yes, stage 1, only a small percentage. Stage 2, you are most of the time in 50% of the night. Yes. Then from stage 2, you go to stage 3. And stage 3 is the deep sleep, like I already mentioned. So you have a further decrease of body temperature, also a decrease in your blood pressure, your heart rate. Everything is very stable in deep sleep, because you are not activated, sympathetic activated, in sense of that it means that you don't have a lot of arousals, otherwise you were not in deep sleep. Yeah, so there is muscle relaxation, and the brain activity in the EEG shows very slow wave sleep. In the whole scope, we see the slow wave activity. So stage 1 and stage 2, in the light sleep, there is sympathetic activation. We can see variability in the heart rate. We can see there is sympathetic activation, so some vasoconstriction, etc. It's more irregular. When the patient in deep sleep, everything is very regular respiratory movement, very regular heart, and normally very stable heart rate, stable respiratory movement, stable oxygen saturation, everything is stable. Then the next phase, from deep sleep, we go to REM sleep. And like I already mentioned, REM is specific to rapid eye movements. And rapid eye movements is when you look at babies, for example, when they are asleep, you can see very easily, very nice how the eyes are moving during the REM. So it goes from left to right and up and down, the rapid eye movements. What we see in REM is that you are active. It's an active sleep. So in REM, we see an increase of the heart rate, with more variability in the frequencies of the heart rate. And what we also see is that the brain activity shows a bit of a more like a wake pattern. So it shows fast frequency activity, low amplitude is different than the high amplitude slow wave, what we see in deep sleep. In REM, everything is from low amplitude, because, and also everything is very unstable, because REM is an active sleep. So we see a more irregular heart rate and irregular respiratory movements, irregular oxygen saturation. But what we also do see is that there is atonia. So we don't see movement. So the patient is not moving because of this atonia. And it's actually important, because otherwise, because in REM, we call it also dream sleep. So we have active dreaming. If you don't have the atonia, you will act your dreams. So there are specific sleep disorders where patients lose the atonia, and are really acting their dreams. And we see this in patients, for example, with the Parkinson disease. So patients with neurological sleep disorders, specific neurological neurological disorders like Parkinsonism, we can see that patients are losing the atonia, and they have what we call REM sleep behavior disorders. So they are acting their dreams because they don't have the atonia. Yeah, and REM sleep is about 20 to 25% of the night. We see the REM sleep, and also the deep sleep in 20 to 25% of the night. Yes. So the physiology of sleep, like I already mentioned, heart rate goes down, blood pressure goes down, the body temperature goes down. Also, your frequency of your respiratory movement goes down normally during sleep, or you need to have some other sleep disorder. Sometimes we can see there is some very quick respiratory movement. The muscle tone goes down. What we see in the brainstem, there is decreased activity in the arousal centers because you are asleep. You will not wake up from everything anymore, and your body is relaxed. Yes, in your and in your brain, it's a very active process. Like I already mentioned, really the brain is cleaning up a lot of stuff. So there are a lot of neurotransmitters involved in sleep. So it's important. There are a lot of things that can go wrong in sleep. So there are over 80 different sleep disorders. So that's a lot. And what we see is we have different ones, like only snoring. People have sleep deprivation, hypersomnia, like that you are sleeping too much. Actually, we have sleepwalking, we have insomnia, troubles to fall asleep, REM sleep behavior disorder, talking in your sleep, night sweating, sleep paralysis, movement disorders, etc., etc. And what we are talking about today is the sleep apnea. Yes, so respiratory related sleep disorders. So when we talk about sleep apnea, we talk specific about two phenomena of sleep apnea, and the most common one is obstructive sleep apnea. And in obstructive sleep apnea, what we see, there is a blockage of the upper airway. Yeah, so when the patient lays down during sleep, the muscles are more relaxed. We see there is an occlusion, a partial or a complete occlusion of the upper airway. So there is not enough oxygen saturation going through the lungs of the patient. So what we see is that the patient has desaturations in their blood. The patient has an arousal, and because of the arousal, he wakes up, airway opens up, deeper breaths, quicker resaturation. So this is how the obstructive sleep apnea looks like. So it's an obstruction of the upper airway, and you can have, and the severity is variable. So you can have like a mild sleep apnea when you have an AHI of 5, between 5 and 15, between 15 and 13, you have the moderate sleep apnea, and above 30 AHI, you will have a severe sleep apnea. And I will explain later what AHI means, because it's the apnea-hypopnea index, and I will explain to you how we calculate it. Yeah. So this is the most common one, obstructive sleep apnea, but we also have central sleep apnea. And in central sleep apnea, there's no obstruction of the upper airway. But what we do see, actually, there's no, from the breathing center in the brains, there's no signal to breathe. So there's no drive to breathe. So your breathing center says in your brains, stop breathing. So you stop for a while, and then you resume the breathing again. Yes? So it's a different phenomenon than obstructive sleep apnea. But we can also see it in our patients when we are looking for, is there sleep apnea? Yes or no? Yeah. So it's less common than obstructive, but we can see it also in patients, and especially in patients with, for example, heart failure patients. But I will show you later in the presentation. Like I already mentioned, from the pauses we have, so from the obstructions, the obstruction leads to an arousal, the arousal leads to a short awakening, airway opens up. So this is the end of the event when the airway opens up. So we calculate all the events, and we count the events per hour and based on the total sleep time, and then we can calculate the amount of apneas, hypopneas per hour. And that's what we call the apnea-hypopnea index. Yes. I will pause here for a minute. Are there any questions? No questions? Okay. Okay. When we have obstructive sleep apnea, I want to show you actually how it looks like and how severe it can be, and actually how it sounds. Yes. So here we start. So there's very heavy snoring in this patient. He's really gasping for air. He's moving. And now you hear everything stops, actually, except breathing. Patient is still breathing. You see the abdomen and the thorax are actually paradoxal movements. So there is an obstruction here in the upper airway, and the abdomen and the thorax are paradoxal breathing. So there's really, patient is suffering. And you can imagine when you are a partner of this patient and you're lying next to this patient, and now he's gasping for breath because there is a deep desaturation. So he's really trying to get in a lot of air to increase oxygen saturation. And now he has another apnea again. So this is a very severe sleep apnea patient, but we see it in common basis that patients has. And especially this patient is now in supine position. There is a blockage of the upper airway. So it's a very severe and a clear apnea case to show you how it looks like and how how intimidating it can be for a partner to lie next to your partner, and he is not breathing and he's pausing for a longer time. And then has this severe snoring. So you can see this patient is struggling. Yes, so it's very important to realize that this patient has a lot of is struggling a lot during the night. Yeah. You can also imagine when you have such a severe sleep apnea and all the time you have this blockage of the upper airway, your saturation goes down because there's no, in the moment there is a blockage, your oxygen saturation goes down. You have a lot of arousals with increases of the heart rate. You can imagine that you will develop some comorbidities. And what we see is that most of the sleep apnea comorbidities is hypertension. Yes, but also congestive heart failure and diabetes are common in patients with sleep apnea. So when you are a GP and you see patients who are diabetic and they have some heart failure issues and they have an hypertension or arrhythmias or AFib or a stroke or maybe a TIA or whatever, it's important to realize that it's important to test this patient if they are sleep apnea, yes or no, because actually the most of the patients have already sleep apnea and have already symptoms and go to the GP, for example, for hypertension, and then they are tired during daytime and they have they cannot sleep and they get sleep medication, etc. So they have a lot of comorbidities, and it takes 6 years to really diagnose the patient. So there are still a lot of patients undiagnosed on sleep apnea. Yes, because you don't have sleep apnea from one to the other day. You know, it's really it's something which develops over a year. You don't have it from one to the other day. So also your complaints and how you feel, and if you feel fatigue or whatever, you think it's part of your being. So a lot of patients, they say that they are not, they don't have actually, they say they have no clinical symptoms, but the partner most of the time, they complain because they hear the patient stops breathing during night and they hear the severe snoring. Yes, and they see the patients are struggling during daytime to stay awake, for example. So it's important, anamnesia of the patient, also the partner, is very important. Yes. So what's actually the patient pathway? When we, in most of the European countries and also in the Netherlands, they start when a patient has symptoms and he goes to the GP and he gets a referral to the sleep center, or he is at a private clinic or whatever. They start with a questionnaire. And the most common questionnaires used in sleep apnea patient, or when you think a patient has sleep apnea, when you you give the patient a questionnaire. And the questionnaire, the ESS questionnaire, is an Epworth Sleepiness Scale. That's the most common one, together with the Stop-Bang questionnaire. We also have the Berlin questionnaire. Those questionnaires are mostly used in patients where they are suspicious for sleep apnea. Yes. When they have a questionnaire and they have a positive questionnaire, so they screen positive on sleep apnea, you can do around a diagnostic sleep test. Yes, and when you got the results of the sleep test, together with the anamnesia of the patient, so the clinical history of the patient, also you need to know what kind of medication, comorbidities, etc. You decide if the patient needs to be treated, yes or no, and what kind of treatment this patient needs. So this is the Epworth Sleepiness Scale questionnaire. So actually, it's very easy for the patient to fill in. So you can score. How often do you doze? Yeah. So actually, it's a questionnaire to see if you are sleepy during daytime, yes or no. So when you're sitting and reading, do you have no chance, or slight chance, or a moderate chance, or a high chance of dozing? Yes. So when you have a lot of 3s and 2s, you have a high score. When you have a total score, when you accumulate this and you have a total score over 10 or equal to 10, there is an advice to do a sleep test. Yes. Then we have the Stop-Bang questionnaire, and the Stop-Bang says, okay, stop is from snoring, if you are tired, anybody observed stop breathing, and are you being treated for high blood pressure? Yes. And the bang says for the BMI, age, neck circumference, the neck circumference, and the gender. Yes. And what we see here, for example, when you are a loud snorer, for example, or you have high blood pressure, yes, and you have a high BMI and you are over 50 years old and you are a male, then you have already a high risk of OSA. Yes. So when you do the Stop-Bang, actually a lot of patients and especially men above 50 years old with some higher BMI or maybe taking medication for high blood pressure do already have an intermediate or high risk of OSA. Yes. So once you've done the sleep test, you decide what type of diagnostic test you want to do with this patient. And in sleep world, in the sleep medicine, we talk about the type 1, type 2, type 3, type 4 sleep studies. Yes. So type 1 is the in-lab sleep study, is the polysomnography in-lab. This is the gold standard, PSG. Yes. So what we measure is brain activity, eye movements, the respiratory flow, chin muscle tone, the heart rhythm with an ECG, body position, respiratory movements in the abdomen and the thorax, pulse, oxygen saturation, leg movement activity, but also video recording and audio recording. So we have the full picture of the patient, but the patient is in lab, is not in his own home environment, so it's in a different environment. The patient is has a lot of electrodes on the head, on the face, on the body, so it's more difficult, of course, to fall asleep. Yes. Then we have type 2 sleep study, and it's actually the type 1, but then the patient sleeps at home with all this materials. So with all the electrodes, with the flow, with the thermistor, with everything, like we have in the PSG. In the type 1, the gold standard. Type 2 is the same, but then at home. So most of the time, no video, no audio, but some, I know some sites, some hospitals, like in the Netherlands, they also do video and audio in home testing. So there is some stuff on the market, but then it's still very time consuming. Then we have type 3. Type 3 is a sleep study at home, and it's the standard polygraphy, but also the watchpad is a type 3 device. Yes. So what do we measure? With the polygraphy, we don't measure brain activity, but we have the flow, yes, the nasal flow, and we have the respiratory movements from the belts, and we have the oxygen saturation. Yes. And the type 4 is more screening, and it's the oximetry. So it's only based on the oximetry. So actually, type 1 is the gold standard, and type 4 is screening. Yes. When you have a patient which is suspicious for sleep apnea, so you have the question, okay, is there sleep apnea, yes or no? You be advised to use a type 3 device. It's a home sleep apnea testing device. Yes, so the traditional sleep apnea testing is not a PSG, and PSG we use more for other sleep disorders, but the polygraphy, home sleep apnea testing device, is the test actually to check if there's sleep apnea, yes or no. We start with type 1. When we look at the polysomnography, so the gold standard, what we see is when we look at this doll, how a patient looks like really in a hospital, because you can imagine with all those electrodes on the head and on the chin and on the face and on the chest and abdomen, everything, also the respiratory belts, it's important that they stay in the right place. Yes, because when the thorax belt became the abdomen belt, because it's moving, you don't want it because you don't have a good signal, a clear signal. So it's very important that you stick everything in the right place. So you put a lot of adhesives on this patient. Yeah. So what we measure is EEG according the 1020 system. So specific places on the scalp, EOG, eye movements, important to measure eye movements for wake and also for REM sleep, of course, the rapid eye movements. EMG, chin, important also to detect, to look at the REM and also the wake periods, and if there are some bruxism, yes or no. Then we have the nasal flow and the thermistor below the nose. The nasal flow is it measures the pressure, and the thermistor measures the difference in temperature in the breathing. So like the ingoing air is colder than the outgoing air. Then we have the respiratory effort belts. We have the oxygen saturation, we have the sound, we have the body position, so how the patient is lying in the bed, in the supine position or on the side. We have the EKG, so the heart rate, and we have the muscle activity, so the on the legs. So we have a lot of signals, and we have also a lot of data, of course. We have video also, and we have audio. So what we see is we measure brain activity, like I already mentioned, and we place it according to the ASM guidelines, the American Association of Sleep Medicine, according to the 1020 system. So we place these electrodes on the frontal scalp. We place it also on the central and the occipital. Yes, so it's important to measure the brain activity in the different regions. We also place electrodes behind the ears or on the ears. Yes, it's important for the derivations. From these electrodes, we measure brain activity, and brain activity is different in all the sleep stages. Yes, so when a patient is awake, we have fast brain activity. Yes, and especially when the patient is closing their eyes, we see the alpha rhythm on the occipital region. Yes, so we can detect if the patient is awake or the patient has closed his eyes, yes or no. Stage 1 and stage 2, like I already mentioned, are the light sleep. So in light sleep, we can see that the brain activity slows down. Yes, in deep sleep, even more. So we have the slow wave activity, and in REM, we can see the brain activity is getting faster. It looks a bit like wake, even faster than wake, fast frequency, low amplitude. So what we see in this, in patients, although every patient has different brain activity and different sleep pattern, because some patients have a lot of very high amplitude delta waves, others have a lot of eye movements during REM sleep, others have less. But we see specific activity during the specific sleep stages. And also in the PAT signal from the watchpad, we can see those specific features, and we don't see the brain activity. But like I mentioned before, when I was explaining about the sleep stages, we can see a difference in sympathetic activation and in heart rate variability. Yes, so it's important to realize that also that each sleep stage has different features in an EEG, but also in a PAT signal. So the EEG is what we got from the electrodes on the head. And when we have everything together, the PSG data, this is what we got from the EOG, and the chin EMG, the EEG, and the ECG. So we have here, this is a 30-second page. We can see here brain activity. We can see the patient is in stage N2. This is a K complex with sigma activity. And this is an arousal. And during this arousal, we can see there is an increase in muscle activity. So this is a chin muscle. We can see there is some eye movement, and we can see that the brain activity frequency is getting higher. Yes. When we relate that to the respiratory movement, we can see here is the airflow. This is the termistor, the thorax, the abdomen. Yes, this is the snore, the sound. These are the movements. So the right leg, the left leg, and this is the oxygen saturation. Here we can see 1, 2, 3, 4 scored obstructive sleep apnea events. And why an obstructive apnea? Because there is no flow at all. So there is a complete closure of this upper airway. This is actually what we saw in the video I just showed you. There is a complete occlusion, and we can see here the paradoxal breathing in the thorax and the abdomen. Yes, and it ends by an arousal. And the arousal we see here. And when we correlate it to the EEG, we can see that there is an arousal in the EEG with fast brain activity, muscle activity on the EMG. Yes, so this is sympathetic activation, heart rate goes up, and there is movement on the legs. Yes, so this is typical an obstructive sleep apnea event. When we look at the polysomnography, we have the type 1 and we have the type 2. In the type 1, the pro and the cons we see here. So what we can see with an in-lab video, we can see the pros is that there is a lot of data. We have audio, we have video, yes. We have patient and signal monitoring. Yes, so with the video, when we look back in the video, you can have a retrospective check for parasomnia, for example, also for REM sleep behavior disorder, for mask leak, etc. You can have a split night opportunity, and you can also directly fix electrodes, or when there is a mask leak or whatever. That are the pros, but there are also a lot of cons because it's very time consuming, very high cost. Not only it costs a lot of time to prepare a patient, to stay awake with the patient, but also to do the interpretation of all this data, because you have a lot of data, and you have audio and you have video. So these patients who have a type 1 test, it costs a lot of time. Yes, so you get a lot of information out of it, and you do it for specific sleep disorders. Yes. Also, a con is that the patient is in a different environment. It's burdensome for the patient. you know. There is a first night test with maybe not representative as a normal night, so you have a first night effect. And it requires very skilled technologies because it costs a lot of time and a lot of effort and a lot of dedicated technologists. Type 2 at home, also a lot of data, patient is own environment, but also again, time consuming, high cost, because we have the same amount of data, no video maybe, but a lot of data to do the interpretation. It's burdensome for the patient, a lot of electrodes, and there's a higher failure rate. Why? Because the patient is at home. There is no opportunity to directly fix electrodes or whatever. And we still have the first night effect because everything the patient has a lot of electrodes, and it still requires skilled technologies. Okay, but when do we use it? It's important in neurological sleep disorders. You really want to see what's going on. You want the video. For example, REM sleep behavior disorder. You need the story, of course, of the patient, but you really want to see what the patient is doing during the night. So it's very helpful to have video, to have audio, to have the EEG, to have also the movements. So it's important for neurological sleep disorders that you have a full gold standard sleep test. Patients with insomnia, you can use it, but most of the time those patients, they don't sleep already when they are at home with no electrodes and with no sensor on the body. So it's very difficult for those patients to have a PSG, but sometimes you really want to see and look at the brain activity, what's really going on. Patients with hypersomnia, like narcolepsy, you really need an EEG because you want to score, you want to be sure of the REM staging. Patients with parasomnia, you want video, movement disorders, also in children. And in children, you also need the TCO2 measurements. And with the TCO2, you really need the patient to have it in the hospital. Same with CPAP titration, you want to have the patient in the hospital when it's not an auto CPAP. And you can do a type 1 and a type 2 if other diagnostic tests are not conclusive. So sometimes you do a type 3 because you think the patient has sleep apnea, and then from the type 3 test you think, okay, there's maybe sleep apnea, there is no sleep apnea, but there are other things going on. And we really want a PSG, a type 1 or a type 2. So, but what we are talking about is about obstructive sleep apnea. And when we want to diagnose patients, what means obstructive sleep apnea? What do we see in a patient? Actually, this is what we see. So the patient falls asleep. There's a collapse of the upper airway. The collapse of the upper airway leads to an apnea or an hypopnea, which leads to a desaturation. Yes, and that leads to an arousal. This arousal leads to an open airway, leads to a resaturation. Patient had the deeper breaths like we saw in the video, and then the patient falls back asleep. And when you have patients with a very severe sleep apnea, we see this sometimes like 60 times per hour. So every minute, this patient has a collapse of the upper airway. Sometimes there is a duration of 20, 30, sometimes 40 seconds. So the patient has actually collapse, then an arousal, resaturation, few deep breaths, falls back asleep, and again a collapse of the upper airway. So you can imagine that these patients really suffer also during daytime because they will not fall in deep sleep, because I told you deep sleep is a very stable sleep. Everything is in rest. Patient has a very stable heart rate, stable respiratory movement, stable saturation. Everything is stable. What we see in patients with severe sleep apnea, they have all the time arousals because of the upper airway collapse. So all the arousals leads to no deep sleep at all. And deep sleep is important for your recovery, your physiological recovery. Yes, so this is also why the patients are very tired. They cannot, they are not, they are not willing to do exercise or whatever because they are so tired all the whole day. So it's important to realize. So, like I already mentioned, we score apneas and hypopneas when we do a flow-based device according to the ASM guidelines. And hypopnea means a partial occlusion of the upper airway when we see flow limitation of 30 to 90%. When there is an apnea event, there is a total blockage of the upper airway. So there is flow limitation of 90% or more. Yes, so that's how we measure it with the flow. So this is how hypopnea looks like. So we speak about hypopnea, 30 to 90% flow limitation with a 3% or more desaturation and or an arousal. That's what the ASM guidelines say. So with a minimal duration of 10 seconds. So here we see the flow limitation. We can see the desaturations in this patient, flow limitation, desaturation, snoring, everything what we see says, okay, this is a partial obstruction of the upper airway. Yeah. This is an obstructive sleep apnea. This is what I just showed you, complete blockage of the upper airway, also with desaturations and with arousals. When we are talking about type 3 devices, home sleep apnea testing devices, we can use the polygraphy. So this is no EEG, only flow measurement, yes, and abdomen and thorax, and an oxygen saturation, yes. But this patient still has the flow and the belts and the oxygen saturation, so we are not measuring total sleep time, yes, and we are not measuring arousals, because we cannot measure arousals from this only these sensors. But what the guidelines say, okay, for a technical, adequate home sleep apnea testing device, you need a minimum of the following sensors, so nasal pressure, chest and abdomen with platysmo and oximetry, or PAT signal with oximetry and actigraphy. Yes. And when we're talking about the PAT, we're talking about our WatchPad device. So this is the WatchPad 300 and this is the WatchPad 1. And the WatchPad 300, we have a reusable device, and the WatchPad 1 is a disposable device. They both measure the same. We have the same sensors in both devices. This one, the WatchPad 1, works with an app on the cell phone, so you can send it to the patient. The patient can run the sleep test at home. It can end the recording in the morning when he wakes up. Data will be uploaded to a cloud, and you have immediately the same day when the patient stops the recording, the data is uploaded in your cloud. You have the results, so you have the report and you have the raw data. Yes, with the WatchPad 300, the patient needs to bring back the device, and you need to upload the data from the device. Yes, what we measure is the same. So we have a watch, both devices, and I will show it here. The watch is actually, there is an actigraphy in it, and the actigraph measures the movements. Yes, it's important for the algorithm to detect wake versus sleep, because the WatchPad is detecting sleep. Then we have the probe, the specific PAT probe, and in the PAT probe there is an oximetry sensor. So we measure the oximetry level, the saturation level in these patients, like we do with the polygraphy and a polysomnography. Yes. We also measure the PAT signal, and PAT stands for peripheral arterial tonometry. Yes, and it's a reflection of the sympathetic activation. It measures the blood flow through the arteries. Yes, so the heart is pumping. We are measuring the heart rate also. The heart is pumping blood. Yes, and you measure in the heart, in the finger, the beat to beat, yes, heart rate. So you measure the blood flow, and when you measure the blood flow, you can easily see when there is an increased sympathetic activation, the patient will show a lower PAT amplitude when there is an arousal because of the vasoconstriction. Yes, so what we measure with the probe, peripheral arterial tonometry, yes, so the arterial tone. So when a patient has vasoconstriction, you can see the decrease, you can see the vasoconstriction. We also measure the heart rate, the beat-to-beat heart rate. So when there is sympathetic activation, a sympathetic arousal, you will find the increase of the heart rate. And we measure the oximetry. So the watch, actigraphy, probe, oximetry, PAT, and heart rate. Then we have also a sensor on the chest. We have it in both devices, and there is an accelerometer in it. And this one measures the body position. So in what position patient is sleeping? Is he in supine, on the side position, or is he in prone position? And it also measures the chest motion. By sampling 5 times per second, we can see the movement of the chest. Yes, it's important for the algorithm to detect central versus obstructive. Then is in the sensor also a microphone in it. And in the microphone, it measures decibels of sound. So it measures 1 meter from the patient, it measures inside. So we can really see if the patient is snoring a lot, but also when the patient is moving a lot, we can get it also from this sensor. So you need to be aware, and you can see in the raw data what's really going on. Yeah, but also in the report, you can get already an idea if it's really snoring, yes or no, or related to movements. So that's the sound. So we have 3 points of contact. So we have the watch, we have the sensor on the finger, and we have the sensor on the chest. And these 3 points of contact give you a lot of information. Yeah. So what is actually the PAT technology? Like I already mentioned, it's the peripheral arterial tonometry signal. And by using this unified pressure field, yes, we can increase the sensitivity. Yes, it increases the dynamic range of the signal and it prevents from blood pooling. So actually the PAT technology is the PPG, yes, plus the unified pressure field. And the patient needs to place the probe in a good way around the finger. There is an adhesive which you need to take out, so the probe is really stick to the finger, so it stays on one place. There is a pressure field in the probe, so we can really measure very slight variability changes in the arterial tone. We can measure in the PAT signal. So it's important to have the unified pressure field. So again, what's PAT technology? Uniform pressure field is important. Yes. So there is a photoplethysmography. Yes. And we measure from that the PPG with a unified pressure field. We have the PAT signal. And this is your pulsatile volume. This is how we can see the heartbeat of each patient. Yes. So this is the PAT. This is actually your cycle of your heartbeat. Yes, so this is your systole, this is your diastole, and this is your diacritic notch. So your systolic phase in your PAT signal, your diastolic phase, and your PAT amplitude. And the PAT amplitude is important. The changes in the PAT amplitude are a reflection of the sympathetic activation. Yes. So when we look at obstructive sleep apnea, the flow-based devices look at the collapse of the upper airway based on measuring of the flow. Yes, so they measure flow limitation, hypopnea or apnea events. And on the sensor, they measure desaturations. Yes, but the polygraphy is not measuring an arousal. The watchpad is not measuring flow limitation because there is no flow, but it measures the arousal. Yes, so it measures sleep apnea, but just in another way. So it's not measuring flow limitation, it measures arousal based on this flow limitation obstruction of the upper airway. So actually the technology in a nutshell of the sympathetic activation, we can see here at 1 that the patient has an obstruction of the upper airway. Because of the obstruction of the upper airway, the saturation level in the blood goes down. Yes. When the saturation level goes down, CO2 rises. You get an arousal in your breathing center. This arousal leads to vasoconstriction. Yes, and this vasoconstriction we can see in the raw PAT signal. We can see a lower PAT amplitude at this point. So when we look at what kind of signals we get from the probe, we have the oxygen desaturation. So here we see the desaturation. So this is a part of a 10-minute time window. Yes. So we see here three desaturations. Yes. This is the PAT signal. So this black stripes, actually, these are the pulses. Yes, so the heart is pumping. So what we see here actually is the pulse rate. Yes, so from the PAT, we have the PAT amplitude, which is an envelope of this raw PAT signal, but we also have the beat-to-beat pulse rate, the heart rate. Yes, here we can see the vasoconstriction. This is the moment of vasoconstriction. This is a moment of vasoconstriction. This is a moment of vasoconstriction. So the PAT amplitude goes down. And the moment the PAT amplitude goes down and the heart rate goes up, we say this is sympathetic activation. This is a sympathetic arousal. This is your fight-flight mechanism. Yes, because the patient has an arousal, because O2 goes down, CO2 rises up, arousal, and after the arousal, airway opens up, and we see there is a quick resaturation all the time. This is only based on the probe, on the finger. Yes, we got these signals. We are also measuring what I said, the total sleep time. Yes, based on the actigraphy of the wrist. So the watch around the wrist, there is an actigraphy in it. Sleep versus wake. But we also measure non-REM versus REM, and even light sleep and deep sleep and REM sleep. It's not as accurate as a PSG. It cannot be. But we have a very good correlation with the PSG, with the EEG and the watchpad. We are measuring non-REM and REM based on sympathetic activation. So the amplitude of the PAT signal and also the PAT variability and the heart rate variability and the heart rate frequency. Yes, of course, we also have the oximetry, we have the actigraphy, so we have different kind of channels, but based on that, on the heart rate variability and the heart rate frequency and the PAT variability and the PAT amplitude, we measure the non-REM versus REM. So what we do, we calculate apneas and hypopneas, not based on flow limitation, but based on desaturations and arousals. And we have the total sleep time. So based on this estimated total sleep time, we calculate the AHI. Yes, so we calculate the number of events, we divide it by the total sleep time, so we know the amount of events per hour. What's the correlation with PAT versus flow-based devices? So what we see here we see the raw PAT signal, the PAT amplitude and the heart rate and the oxygen saturation. Yes, this is the actigraphy. And this is the NAV. So this is the flow from the PSG. So there was a PSG simultaneous with the watchpad. What we see here, and here is the event. So we see a complete flow limitation, an apnea event. Yes, so that's 90% or more a flow limitation. Yes, we see during this event here, there occurs a desaturation. Yes, and here the patient has an arousal. So we see here the resumption of breathing in the NAV. And we see here also, when we look up, we see that here, at this moment, there is the arousal. We see in the PAT signal. So the PAT signal scores a respiratory event, apnea, hypopnea event, before the arousal, because the arousal is a result of the obstruction of the upper airway, what we see here. So actually, this is what we measure in a flow-based device, a flow limitation. We are measuring the result of the flow limitation, so the sympathetic activation, the arousal. Yes. So what we can see here, very nice, the correlation between flow limitation, the patient starts breathing again, resumption of breathing, and the arousal. And after that, of course, after the arousal, patient starts breathing again, we see a quick resaturation. That was an apnea event. Here we see the hypopnea event. So there's a flow limitation of 30 to 90%. So there's no complete blockage of the upper airway. Patient is there's still air going through, like we see here. But also here we see that the patient here resumes breathing, some deeper breaths. It's also during the arousal over here. Yes. So patient desaturates. Here we see the arousal. After the arousal, resaturation. Yes. So there's a very nice correlation also between the hypopnea events. And it doesn't mean that a hypopnea event has a less strong arousal than an apnea event. It depends also per patient. When we look into the raw data of the watchpad, this is a very severe case. We can see here, this is all night window. So we see here the heart rate channel with all those marks are all scored events. Yes. And this green block over here is reflected here. Yes. And blue is the wake period and pink is the REM period. Yes. So blue is wake, pink is a REM period. So what we see here is this green block over here is reflected here. So this is the actigraphy channel. Yes, this is the body position. So the patient is in supine position. This is the snore, the sound. You can see here that the patient, when there is an arousal, there is some deeper breath, there is some snore in this patient. Yeah. Then we see here the respiratory movement. Yes, this is a saturation curve with the desaturations. This is the PAT signal, the PAT amplitude, and the pulse rate. So what we see here is that in this 5-minute window, we see 1, 2, 3, 4, 5, 6, 7, 8, 9 events in 5 minutes. Yes. So it means that this patient has a very severe sleep apnea, because when you say, okay, 9 per 5 minutes, it means that there are over 100 in 1 hour. Yes. So it's a lot. And all those events are together with desaturation. So you can imagine that this patient suffers a lot because all the time it's correlated with arousals. So it has influence on your cardiovascular system. We can see it also here in the PAT signal. So it's important to realize how the system works and how we detect apnea hypopnea events. So it's not based on flow limitation, it's based on an arousal with a desaturation. Yes, so reciprocal pattern, desaturation, and the apnea of the algorithm places an apnea hypopnea event before the arousal, an obstructive one. Yes, because we make also a difference between obstructive and central. I will explain. Based on flow limitation, we can say, okay, this is an hypopnea or this is an apnea event. Yes, but we don't have flow. So we are not making difference between apnea and hypopnea. Yes, you can do, if you want, you can go to the raw data to see what's going on. Yes, we are also not measuring the length of the events, the duration of the events. Because we measure the result of the upper airway obstruction, so the arousal and the desaturation. Because sometimes when you have a PSG and you have sometimes 9-second flow limitation, if you follow the rules, you may not score it, but it could be that you have 9 seconds flow limitation with desaturation of 6-7%, for example, with an arousal, and you may not score it when you follow the guideline because it's not 10 seconds. Yes, so it's better. And of course, when you do a PSG and you see this kind of events, you put it in the report and you describe it what's going on, because the reaction of the body is as strong if it's 9 seconds or 12 seconds. It doesn't matter. Yeah. So when you have a total blockage of the upper airway, and we have no flow, of course, but we can look at the snore signal. The snore signal can be very helpful, and also the respiratory movement, to see what's going on, if this patient has a more apnea or a hypopnea event. And we look at this screenshot, what happens when there is an occlusion of the upper airway, you have a gradual desaturation. Yes, that's what we see here, a gradual desaturation. There is an abrupt arousal. That's what we see here, abrupt arousal. The airway opens up. The airway opens up. We see it here, a big increase in snoring. So there is a sudden deep breath with a snore. Yes. And what we see in the saturation, because the patient is taking deep breath and breathing normally for a few times, there is a quick resaturation. Yes, that's what we see here. This is typical for obstructive sleep apnea. So when we look at the snore channel, we see during the event, there's no snoring because there's a total blockage of the upper airway. Yes, but when there is an arousal, the patient starts snoring because arousal, airway opens up, deep breath. That's typical for an apnea event. Yes. Hypopnea looks different. Here we can see this is during a hypopnea event. There is a partial blockage of the upper airway. So it's not a complete blockage, though there is snoring, there is sound. We see increased snoring during the event. And when there is an arousal, the snoring stops because the airway opens up and the patient is free to breathe. So there is no snoring and stop snoring. That's typical for hypopnea. And those two are apnea events. During the event, no sound. When there is an arousal, snoring starts. Yeah, and here we see the same. So we are not giving an apnea index and a hypopnea index. We only give an apnea hypopnea index. But when you want to know if it's more hypopnea or more apnea, go into the raw data and you can get a lot of information out of the snore signal. This is a nice example for where we see that the patient, this is a 10-minute window, 5-minute window, sorry, 6-minute window, where we see here, the red one is a snore, is the sound. We can see here all increased snoring with increased respiratory effort. The patient is really doing her best to breathe. And then there is an arousal. There's no desaturation, a very mild one, goes only down for 2% of 2. Yeah, from 96 to 94. So not enough for the algorithm to detect a desaturation because it's not 3% or more, but there is an arousal. Yes, so there is an obstruction of the upper airway and there is an arousal. So the algorithm will score a respiratory event. Yes, here the same. We have increased snoring, increased respiratory effort, and the by an arousal. Yes. So even though there are no desaturations, we have a real reciprocal pattern. We see the vasoconstriction, we see the arousal, and we see the relation of the snoring and the respiratory effort and the arousal. Yes. So it's important when you go and review the raw data, you can get tons of information out of it. It's important that you look, okay, what's going on? You go from left to right and from top to bottom, you correlate all the signals together, and then you get a lot of information out of it. Like I said, I already mentioned, we also detect central sleep apnea. And what is central sleep apnea? There's no drive to breathe. So the patient stops breathing. So we see no movement on the chest, no movement on the abdomen, no flow, no intermissal, because the patient stops breathing. We see this in patients with, most of the time, patients with heart failure, patients with strokes, patients who use opioids. We can see specific biotic breathing pattern. Yes? In patients with heart failure, we see most of the time Cheyne-Stokes respiration. Yes? So it's specific pattern. So sleep is really also recognizing patterns. Yeah, like you do in a PSE and in a polygraphy, you also recognize patterns in the watchpad data and the watchpad signal. So how do we detect central sleep apnea? First of all, the electrode on the chest is very important. Yeah, because the chest during the event will not move because there's no breathing. Yes, so we will have a straight line on the chest. Yes, this is for the algorithm a signal that this is central. Then also the upstroke, and the upstroke means the PAT upstroke. We don't have it in the raw data, but the PAT upstroke reflects the angle of the raw PAT signal. What's happening when a patient has an obstructive sleep apnea event? Yes, there is a lot of stress, actually, a lot of strength on the vest because the patient is breathing. There is paradoxal breathing. Yes, but here is an occlusion. Yes, and there is increased negative pressure, and there is change in interthoracal pressure. So it means there will be a change in the PAT upstroke. in the variability of the PAT upstroke. So you will see that during obstructive event, there is a change in the upstroke of the raw PAT signal. When there is a central sleep apnea, yes, there is no upper area obstruction, and the patient, there's no change in intertoral compression because the patient is not breathing. So you will not find a change in the PAT upstroke, yes, or a minor change in the PAT upstroke. It looks different compared to an obstructive sleep apnea event. So chest and upstroke are important for the algorithm to detect obstructive versus central. Then we also look at the oximetry, because like I told you, in an obstructive sleep apnea, there is a gradual desaturation. There is an abrupt arousal, and after the arousal, we have a quick resaturation. It's typical for obstructive, yes, because airway closes, goes down slowly, arousal, deep breath, and a quick resaturation. When we have central sleep apnea, and I'm talking about the Chine-Stokes respiration, we see a very symmetric de-resaturation pattern, yes? We see, of course, also in the breathing pattern on the respiratory movement, we can see the periodicity in the breathing with the central events. And we see related to that, the desaturation, resaturation pattern in the oxygen saturation, yes? Also in the actigraphy, it's on the wrist, but when the patient has his arm near his body most of the time, we can also see it's a very sensitive device. So we see the movement in the chest. So we can see also respiratory movements reflected in the actigraphy sometimes. So we can see also when there is central event, we see a lot of times also we see the central part in the actigraphy with the resumption of breathing again. So we see also the respiratory movement in the actigraphy. And of course, the snore channel, the sound. In obstructive sleep apnea, it looks different than when there is a central sleep apnea. Yes, and also the moment, the nadir of the desaturation, the moment of the arousal is different in a patient with Chine-Stokes respiration than a patient with obstructive sleep apnea. So here we see raw data. Again, PAT signal, PAT amplitude, reflection of the PAT signal. So we're looking here in a 2-minute window. Yes, we see here the PAT amplitude. So it goes out. So here we see the arousals. Yes, here we see the arousal is in the nadir of the desaturation and in the middle of the hyperpnea phase. This is typical for Chine-Stokes respiration. Yes, so we see the very symmetric de and resaturation pattern. This is a respiratory movement with very short central events, and the patient starts breathing again. Central event, patient starts breathing again. This is typical Chine-Stokes periodic breathing, and the moment of the arousal is different in central versus obstructive sleep apnea. And also the desaturation, resaturation pattern is different in central versus obstructive. Actigraphy, we see during the event, no movement. Yes, when the patient is breathing again, we see the movement is coming. And also the snore is not really snoring, some deeper breath. We have the central index also in the report. So we give the PRDI, the PHI, which stands for PAT, PAT apnea hypopnea index, because it's measured by PAT signal, not by flow. Also the central index we have in the report. Yes, the central index is part of the total AHI. So this patient in this case has a PHI of 59.2 because the all-night index is 59.2, and from this 59.2, the central index is 48.5. Yes, so there is almost there is 10.7 obstructive index. Yeah, and we see the percentage Chine-Stokes respiration is based on the periodicity and is based on the total sleep time. When we look in the raw data, we see this typical phenomenon in this is actually the central sleep apnea Chine-Stokes respiration compared with obstructive sleep apnea. Yes, here we see the reflection of the respiratory movement in the actigraphy with the central events in the actigraphy, and here we see in the actigraphy also the respiratory movement, but we can see that during the event the patient is still breathing. We see the same here in the respiratory movement channel, where we see the central events here. We see the periodicity of breathing, the waxing and waning. Yes, what we also see in the periodicity in the D and resaturation pattern, with again the nadir more in the middle of the hyperpnea phase and in the moment of the arousal. Yes, here we see the arousal is in the second part of the desaturation, and after the arousal, a quick resaturation. It's a different pattern when we compare obstructive versus central. Yeah. This is another case in a patient with a very severe, ultra high HI, also above 100, a lot of events scored. And this is a small window, yes, from a 5-minute window from this patient, where we can see a specific breathing pattern. So we see very short central events and 1 or 2 breaths. For a short central, 1, 2, 3 breaths. So this is 2, 3 breaths. It's very typical. Yes, it's central. This is a central case. It looks like a central event, but what's going on? This is a typical biotic breathing pattern. Yes, so short central, 2, 3 breaths, short central, 2, 3 breaths. This is very specific in patients who are using opioids. This is a patient is using methadone, a lot of other comorbidities, a lot of other issues, but he's using methadone in a high dose, and we see this the whole night. We see this kind of breathing pattern. Yes, so you have to be aware when you see this kind of breathing pattern. It's or related to opioid use, or there could be something wrong, some lesion in the pons, or maybe a tumor or some bleeding or whatever. Yeah, so you have to be aware of that. Mixed apnea events. Yes, the mixed apnea events, we say the pathophysiology is based on coexisting ventilatory control instability and upper airway collapsibility. It's very rare to have mixed events over the whole night, yes, but mixed events in obstructive sleep apnea, we see quite a lot, and more towards the end of the night. For example, when we have very severe sleep apnea patients, towards the end of the night, it can develop from obstructive to mixed and sometimes a bit central. Yes. What we see in a mixed apnea events that it starts with the central part and then we see an obstructive part. Yeah. It looks different than a normal central. Also, the D and resaturation pattern looks different. It looks more obstructive versus central. Yes. So we are not scoring it. If you see this kind of, if you have some doubts, if it's scored as central and you have some doubts, go in the raw data and check. But it's rare that there are a lot of mixed events. Yeah. So again, what do we measure? Apnea-hypopnea index, measured by oxygen desaturations and arousals, and based on the total sleep time, we calculate the AHI. Yeah. Also, we look at sleep structure. So this is what I already mentioned. In the different sleep stages, we see different activities. Yes, so also different sympathetic activation. Yeah. What do we see when we look at the sleep staging in the watchpad? We look at the PAT signal, the PAT variability, and also the pulse rate and the pulse rate variability. Yeah. In light sleep, yes, there is the patient is relaxed, but there's still some variability in the pulse rate. There is variability, there is some sympathetic activation, there are some arousals. This is what we see in the PAT. So there is some PAT variability, yes, and we see variability in the pulse rate. Yes, so variability in the frequency of the pulse rate. When the patient is in deep sleep, yes, so the slow wave sleep with the high, low frequency, high amplitude EEG, everything in deep sleep is more stable. So we see a more stable heart rate, a lower mean heart rate. That's what we see here. And because there is not a lot of sympathetic activation, there is vasodilatation. There is a broad PAT amplitude, a high PAT amplitude. And there is still some variability, but less changes compared to light sleep and REM sleep, for example. Yes, this is typical deep sleep. Then what we see here, the change in the heart rate, but also in the PAT signal, typical for REM. REM is a very active sleep, yes, although the patient is not moving because the patient is atonic. Yeah, there is atonia. What we see in the PAT is a lower PAT amplitude. There is a higher sympathetic activation. So we see a lower PAT amplitude. And there is variability, PAT variability. Yes. The pulse rate shows also a lot of variability in the frequency of the pulse rate. Yes. There is overall, in general, there is a higher mean pulse rate with higher pulse rate variability and a lower PAT amplitude with also a higher variability in the amplitude of the pulse of the PAT. So actually what we see is we see a smile in the PAT signal. We see a lower PAT amplitude. Yes. So this is typical for REM sleep. Yes. More variability. Everything is irregular in REM. Yes. So the brain activity, but also heart rate variability, the PAT amplitude, the respiratory movement, the oxygen saturation. Everything is less stable in REM. So when we look at EEG compared to PAT, and it's in different time windows, but to explain you, in wake, there is fast low amplitude EEG activity. There's increased muscle activity. Yes, when the eyes are closed, the patient is more in rest, but in the PAT signal, we see still there is sympathetic activation. There's variability. There is some lower PAT amplitude. There is variability in the PAT amplitude and also in the heart rate variability. When the patient falls in a light sleep, we see specific brain activity, increase in theta, slow eye movements, K complexes, sigma activity. What we see in the PAT, there's variability in the PAT amplitude quite a lot. There's sympathetic activation, and the heart rate is getting lower compared to wake, but still there is variability in the heart rate. In deep sleep, slow wave sleep, everything is in rest, low chin, low heart rate frequency. We can see the PAT has a very broad amplitude, yes, a high amplitude, very stable, also a very stable pulse rate. Yes, this is typical for deep sleep. In REM, we see actually a bit the same pattern as we see in wake, between wake and light sleep. We can see that everything, the PAT signal is low, variability in the PAT signal, variability in the pulse rate, and also variability in the oxygen saturation. Yes, and in the EEG, we see the specific rapid eye movements, of course, with the atonia. Yeah. So again, PAT signal is getting lower, the amplitude is getting lower. There is sympathetic activation during REM. This is a REM, the eye movements over here. Yeah, so this is specific for the PAT. PAT amplitude goes down. So here we have a nice case. This is a normal sleep, a patient with a normal sleep. This is an 8-hour sleep in a patient where we can see very nice, when we look at the PAT signal, we can see very nice the periodicity in sleep. Only by looking at the PAT and the PAT amplitude and the pulse rate and the oximetry. So this is what we got, the 4 lowest channels, the 4 channels below, oxygen saturation, PAT signal, PAT amplitude, pulse rate. Here we can see the patient falls asleep. This is in light sleep, stable saturation, but a lot of variability still in heart rate and also a lower PAT signal. The patient is still active, some higher heart rate variability, not related to desaturations. Yes, then here, deep sleep, very broad PAT amplitude, low, stable, very stable saturation, not low, this is 96%, high PAT amplitude, and a lower mean heart rate with not a lot of variability. Patient is moving, increase in the heart rate, change in body position, and we can see here the decrease of the PAT amplitude and the increase of the heart rate and variability in the oxygen saturation. This is typical REM stage. So this is the first REM period in this patient. And we have 4 more, yes? And this is the other one. And this is the following one, yes? And we can see actually the periodicity in the sleep. Here is one next, and here is another one. So what we can see here also, the first part of the night till 4, we have less sleep, less REM sleep, more deep sleep. Second part of the night, there were more REM periods and some less deep sleep. Yes, so this is actually a very nice reflection of a normal sleep only based on the PAT signal. Yeah. When we zoom in on a 1 hour window, because in an EEG, we look at 30 seconds. Yes, with a watchpad, it makes no sense to look at 30 seconds when we look at the sleep staging, or also when we look at the sleep staging, sorry. When we look at sleep staging, we look at a broader pattern and we look at change in patterns, yes? So we look at the whole night window and then we zoom in on a 1 hour or 2 hour time window. So here we look in a 1 hour window where we can see very nice, the pink period is the REM period. We can see when we compare it to the non-REM over here, in the wake and the non-REM over here, this PAT activity is a different activity. Also, the heart rate is some higher mean heart rate with more variability. This is specific REM stage. Yes. So when we zoom in, yes, we can see, and maybe this one starts a bit earlier. You can easily adapt in the raw data. You can lengthen the REM stage or whatever. But the most important thing is that we can see if there's REM-related sleep apnea, yes or no. Yes. So it's important to detect REM. Here is another one, another example how to detect REM, because here we can see that actually there is the PAT amplitude. We look at, here is this patient has events. Yes, we see that, for example, there are some blocks of events over here where we see desaturations. But what we also see in the pulse rate, that there are periods with a higher mean heart rate over here and over here and over here and over here. Here we see the decrease in the PAT. Yes, also here, decrease in the PAT signal. We see it here, and here we see it less, but there is increase in the heart rate. So when we look at this, without having the hypnogram, the sleep staging, we can actually define the REM stages only based on this trend graphs, based on PAT amplitude, pulse rate, and also the irregularity in saturation. Yeah. Here are the REM stages. Yes, there are 4. In the period with the increased heart rate and heart rate variability, we see that the algorithm detects REM stages. Yes, this is specific for REM sleep. We talked about how to detect apnea hypopnea events. Yes, we talked about how to detect sleep staging with the watchpad. Yes, so we can get a lot of information out of it. So what we do when we upload the data from the device, or the data is uploaded from the watchpad 1 device, there is an algorithm scoring all the data and creating a report. So actually the algorithm is the technician who already reviewed the data. He places events in the test, he places sleep stages in the test, and then he creates an automatic generated report. Yes, and this report is important because when we have a watchpad test, we start always with a report. Yes, with a polysomnography or polygraphy, you go into the raw data, you go scoring. In the watchpad is already scored, but you go check and verify if you agree with the automatic algorithm, with the automatic generated report. You check if you agree with the scoring. Yes, so you look at the report and see how the algorithm did the scoring, and if needed, you can go into the raw data to specific areas. Yes, and you can easily manual editing, sleep staging, and events, and create afterwards a new report. Yes, so actually you are the driver. You go, you check the report, you check if you agree on it. Yes, you give your interpretation. If not, go into the raw data and you can check and verify some stuff. So how is the automatic generated report actually, how does it look like in the watchpad? So we have, first of all, we have the sleep summary, and the sleep summary means what time did this patient start the study. It seems simple, but it's important information, because when they start the study at 4 a.m. in the morning, you can question yourself if this is normal for this patient, yes or no, or maybe he had already 2 sleep cycles on the couch, or he forgot to start the recording, or he had a party and drank a lot of alcohol before he went for the sleep test, for example. So it gives a lot of information. Start study test, end study time. You have your total recording time, yes, and you have your estimated total sleep time and your percentage of REM sleep. It's important that you know and realize that the algorithm needs 2.5 hours of valid data to calculate sleep stages, yes, and it needs 30 minutes of REM sleep to calculate the non-REM and the REM indices, and 1.5 hours of data to calculate apnea-hypopnea events. So it's only 1.5 hours and you have already indexes. So it's also what we say in the Netherlands, we need at least 4 hours valid data to give a reliable conclusion. Yes, but you need to be aware of the fact that the algorithm only needs 1.5 hours. Yeah. Then we have here the respiratory indices. So the total events are the total number of events are calculated. So the bars, what we see in the report. This is the index, the all-night index. So what we see here is all night, so based on the total sleep time. So here it means that over the whole night, the patient has 18.8 apnea-hypopnea events per hour, calculated on a 3% desaturation, with 3% desaturations. When you calculate with 4% desaturations, it's of course, it's here lower, 12.8. Yes, this is your ODI, 3%. So the index per hour that there was a desaturation of 3% or more. Yeah. Then we find here the central index and percentage of giant stroke respiration. Yes. So number of events, the all-night index, and we have the REM and the non-REM index. It's important if a patient has very REM-related sleep apnea, it could be more correlated, for example, to diabetes or to hypertension, drug-resistant hypertension. You need to be aware of that. We see it also in premenopausal women. They have a low number of total AHI, but a high REM AHI. It's important to recognize those patients because they can be very helpful to treat these patients because they have a lot of clinical symptoms. We see here that the indices are calculated on a technically valid sleep time, and a technically valid sleep time when there are artifacts, so there is noise in the signal, the algorithm takes it as excluded period. So the technically valid sleep time is the total sleep time minus the excluded periods. Yes. Then we have here the oxygen saturation statistics. So the mean, the minimum, the maximum, the mean of nadirs. We have here the number of desaturations, the T90. We have here in minutes, but also in percentage of total sleep time. And we have the pulse rate statistics. Then we have here the sleep apnea severity scales according to the ASM guidelines. And this is an important page. So here we have the trend graphs. And from the trend graphs, this is the page where we start with when we are reviewing the data. Yes. So we start with the interpretation of the report. We start with this page on the report. We start with the trend graphs. Yeah. So what we do is we look at the respiratory events over here. So we can see here where the algorithm scored events. So those blue blocks are events. Yeah. When we look at this, we see the black line is the body position. Yes. And the orange one is snoring, but sound. It's sound. We see sudden increases most of the time when the patient is moving. Here we can see it's really snoring. This is snore signal. So you make a difference between the different patterns. Here we have a sudden increase in sound. When we look down, we see there is an artifact in the saturation. It's when the patient is awake. Yeah, so it's an artifact. So what we do in the report, we look from left to right and we look from top to bottom. And here, for example, we can see very nice that those blocks of respiratory events are predominantly when the patient is in supine position. Yes, and we can also see that during those events, we see deeper desets in some periods. And when we go down, we see it looks like those deeper desets are more in REM. Yes, we see it here the same. So actually, by looking at this, we can see, okay, what do we see? We see there are blocks of events, more in supine versus non-supine, but also in REM, it seems that there are deeper desaturations. Yes, so we get a lot of information out of this, and we can see if the algorithm scored well, all the sleep staging, etc. Then we go to the next page, and in the next page we can see if there is position relation, yes or no. What we already said, okay, looks like there is some more events in supine versus non-supine. That's what we see here. So here we can see the PHI and the ODI in supine with the percentage of sleep in a certain position. And here we can see the index in non-supine. Yes, so in supine, there is an AHI of almost 30, and in non-supine, it's only 8. Yeah, so we have here the positional indices. Here we have the snoring and sound volume. Yes, so we have here actually the minutes and sleep, or the percentage of total sleep time. There is a level above 40 decibels. And what we see, of course, here, that the patient is in a lot of blocks quite a heavy snorer over here and over here. And also when the patient is moving, you can see increases in sound, which you can also see here. Yeah? Then here we have the sleep quality. So this is the total sleep time. This is the sleep efficiency. Yes. So the sleep efficiency is 73%. Yes. And from this total sleep time, we can see here the sleep staging. So we have like 70% almost light sleep here. And we have 70 and 17% deep sleep and 15% REM sleep, something like that. Oh. Yes, so we can see here, very nice, how the sleep stages are divided over the night. We can see the sleep latency, so how long it took the patient to fall asleep, the REM latency, so the moment the patient falls asleep till the first REM period, and the number of wakes during the night. Yeah. So from this report, we have a lot of information. What we also have in the report, in a page, another page where we have the histograms, where we can see very nice the pulse rate and the frequency, the pulse rate frequency actually over the whole night. So from this, we can see when a patient has atrial fibrillation, for example, you have a specific pattern. So you have like a parabol. It looks different when you have bigemia or trigemia, or when you have just a normal heart rate. You can see it actually in one glance from only this histogram. Yeah. Also the saturation level. What's the mean oxygen saturation level? Yes, most of the time during the night. And here we can see it's most of the time 97, 98. So it's okay. The nadirs, the depth of the desaturation. Yes. So here we see most of them are around 93, 92, and there are a few around the 80s. Could be that this is during REM, for example, because in REM you have deeper desets, yeah? Or this is the artifact that we saw, yeah? The depth of the desaturation is normally 4-5%. And here we can see the oxygen resaturation. So after the desaturation events, what's the amount of resaturation? So the recovery after desaturation events. So you get also a lot of information out of this. So we have a 5-page report. 1 page is personal data of the patient, but then we have a second page where we have all the indices that we can find. So the apnea hypopnea index, the oxygen desaturation, central versus obstructive, REM versus non-REM, ODI. And then we have a page with the trend graphs where we get a good picture of how the patient slept, and if there are certain periods where there are events, if it's position relation, is there REM relation, are there a lot of movements, how does a heart rate looks like. So you get a lot of information out of that. Yeah. And then we have this page, also the position page, and we can see the sleep stages chart, like I just showed you. And we have the 5th page where we have this kind of histograms. So it's a lot of information, only based on a watch and a probe and a sensor on the chest. When we compare polysomnography versus watchpad, we have a nice, we have a nice correlation, yes, with the gold standard, almost 90%. So what we see here, for example, in this case, we see there is a typical position relation over here, and the patient is in supine position. Yeah, we see it very nicely here in the watchpad. We can also see it here in the PSG. Yes, so this is here where the patient is in supine in the PSG. Yes, and also here we see the blocks of events with the desaturations. Yes, also the REM looks pretty well scored. Actually, here in the end, there is, by the algorithm of the watchpad, a bit of an overscore of REM sleep. Yes, here we have REM-related sleep apnea. Yeah, where we can see that in the PSG, we can see that actually it's very well scored. And here we have a question here, is REM scored in the PSG, where we are quite sure that this is no REM sleep over here, but awake. Yes. So actually the algorithm is doing very good. What we don't see is the fragmentation between the different sleep stages. We don't see that nice. We can see it in the PSG because we score on a 30-second window. But of course, in the algorithm of the watchpad, we look at the broader pattern. We look at the change in pattern. So you will see less fragmentation in the hypnogram between N3 and N2, for example, or N1 and N2, because we don't have the N1. We only have light sleep and deep sleep. Yes, so you will find less fragmentation. Here is a nice example for the phenotyping of sleep apnea. Here we can see on the left hand, a nice one where we can see a position sleep apnea, positional related sleep apnea, where we can see when the patient is in supine position, there are deeper desaturation and higher heart rate variability, deeper desaturation, higher heart rate variability. And when we go from left to right, we see there are periods of desaturation. And when we look from top to bottom, we see it's in supine position, only in supine position. There's no REM relation. Yeah? Here we see the opposite. It's patient is all night here in almost in left position, but in the specific REM periods, we can see there are deeper desats in REM. So this is REM related sleep apnea. In non-REM, hardly any events. In REM, events with deeper desaturations. So it's important to know in what sleep stage the patient is, because otherwise you can give wrong conclusions. And in the polygraphy, we don't have sleep staging. Yes, so we have it in the watchpad. Here we have a nice case of severe obstructive sleep apnea. Yes, we see there is a big blue block here of scored events. We can see there is a lot of snoring. Yes, actually in all positions. Yes, so we can see here it's not here, it's in patient in supine. We see some higher snoring, but towards the whole night, there is a lot of snoring. Yes, here we can see the saturation curve. In the beginning, when the patient is awake, we don't see desaturations, but here it starts. And here we can see a lot of desaturations from the beginning to the end of the night. Yes. It's related to also the heart rate variability over here and the PAT variability. So from here, we can see this is a very severe case. Yes, when we look at the tabular data, we see that there is indeed a very high index of an AHI with 4% desaturation of 92. Yes, so it's a very high index, a very severe obstructive sleep apnea. Why obstructive? Signs of snoring. Yes, and there are deeper desaturations in REM, which is very typical for obstructive sleep apnea. Yes, so snoring, deeper desats in REM, it's very typical for obstructive sleep apnea. And when we go into the raw data, we can confirm by just clicking in some pages, we can see, okay, this is clear. We have here the arousals, we see the desaturation, we see the snoring, we see there is still respiratory movement on the channel. There's no signs of central there is slow desaturation, quick resaturation. Everything is very typical for an obstructive sleep apnea. Yes, so we can confirm by just have a click in raw data. Okay, this is a clear obstructive sleep apnea event. Sleep apnea case, sorry. Yes. Also, the moment of the arousal, when you look in the raw data, is important, because here we can see in an obstructive sleep apnea, we can see the most of the time the arousal is in the second part of the desaturation. Yes, the patient has an arousal, a very deep breath with a snore, and after the arousal, a quick resaturation. Yes, keep this in mind when we compare it to a central sleep apnea event. Yes, when you want to treat obstructive sleep apnea, yes, there are different treatments. You can use the CPAP, of course, the continuous positive airway pressure. It opens the airway. The patient has to sleep every night with a mask. The mask is blowing continuous pressure through the nose, yes, or when you have a nose-mouth mask, it's through the nose and the mouth, so it's a full face mask. You have different kind of masks, you have different kind of devices. You also have continuous pressure. You also have bi-levels, so BiPAP, so you have a higher pressure when you with inspiration and lower pressure with expiration. So you have different kind of devices, but you need to wear it every night also to keep the airway open. Yes. So, but it's a device. Most of like in the Netherlands, it's still the most used device in patients with an apnea above, like the moderate to severe patients are all treated. Most of them are all treated with CPAP. Yes, for the more milder sleep apnea, the mandibular device could be a good choice, and it will be placed, of course, the jaw more to the front, and it will open your upper airway. But also for more severe cases, sometimes when patients cannot sleep with the CPAP, they prefer a mandibular device above a CPAP device. Then there's also some newer technology, and because also the mandibular device, of course, every treatment for obstructive sleep apnea, you have to wear or you have to activate it each night, because you sleep each night, and it's sleep apnea will not disappear. So you really have to use and to wear everything every night. So it cannot solve the issue. Only when you wear it, you can solve the issue of the obstruction of the upper airway. Yes. The hypoglossal nerve stimulator, what he actually does, it's a sort of a pacemaker where the tongue is a bit actually paced more to the front to open your airway when you fall asleep. So the patient can activate, when the patient goes to bed, he can activate the hypoglossal stimulator to activate the tongue and to pulse and to pace the tongue more to the front to open the upper airway. Yes, they use it in the Netherlands also more and more, but it's based on a protocol. So you need to have a certain amount of HI and not too high BMI, and you need to have first try the CPAP first. So you need to have the CPAP intolerant, mandibular device intolerant, etc. So it's a certain protocol, and then they can see if you are if you can get in contact with an ENT who can place the hypoglossal nerve stimulator. In some patients, it's very helpful. Then we have the central sleep apnea. This looks completely different pattern compared to obstructive sleep apnea. Why? First of all, there's hardly any snoring. When we see increases in sound, in this case, it's most of the time when the patient is moving, changing body position. Yes, so this looks completely different than the obstructive patient I just showed you. Yes, but also here are a lot of event scores. We see a lot of blue blocks. Yes, when we look at the oximetry curve, it also looks completely different compared to the obstructive one, where we had in the obstructive one very severe and very irregular desaturations with deeper desaturations in REM. We have, in this case, actually all the desaturations look a bit the same. You can almost draw a straight line here below. Yeah, so we see that all the desaturations are most of the time the same level of desaturation. Yes, and there are also moments where you can see that the saturation curve is quite stable. There are not a lot of desaturations. When we look in what moment this is in the REM sleep. Hey, that's strange. The obstructive, we saw deeper desaturations in REM, and in this case, it looks like it's getting better in REM. Yes. What is typical in sleep apnea, in central sleep apnea, what improves in REM, it's getting better in REM, it's a Cheyne-Stokes respiration. Yes, and in Cheyne-Stokes respiration, we see most of the time the desaturations, the level of desaturations is all the time a bit the same. Yes, so it's very, very equal. What we also see in this patient, that this pulse rate is very irregular from the beginning to the end. So here the patient is awake. You see a short period awake with a stable saturation. We can see that there is a very irregular heart rate. But it's all the time like this. Also, when the patient doesn't have events like in REM, there is still a very irregular heart rate. This is a sign of atrial fibrillation. Yes, so when you see this in a report, a very irregular heart rate, you need to be aware of the fact that this could be a symptom of atrial fibrillation. And we cannot diagnose with the watchpad atrial fibrillation, but we can flag it. Yes, and hopefully, next year or the end of this year, we will have the CE also for atrial fibrillation detection, because we have already FDA for it to flag atrial fibrillation in the report. Yes, and also arrhythmia in sense of premature beats. So when you see this in the report, go into the raw data to check what's going on. And we see here very nice, actually, also in the actigraphy. This is the respiratory movement. This is the oxygen saturation, the PAT signal. Yes, this is the PAT amplitude, the pulse rate. The pulse rate is very irregular because of the atrial fibrillation. So we don't have the very nice reciprocal patterns, but we see the desaturation and we see the pattern of breathing, which is typical Cheyne-Stokes respiration. Yes, so when we look at this and we click in a 10-minute window and we see this, we can confirm that the algorithm actually did a good job. There is a central index and total AHI of 50, and the central index is 38. So it scored some obstructive, but predominantly central. This is a typical Cheyne-Stokes respiration. Yes, so you can look at the report. Yes, you can do the interpretation of the report and then confirm by just looking to the raw data. If needed, confirm if the algorithm was right, yes or no. We see also, like I already mentioned, when we look at the attenuation of the PAT, it's in the nadir of the desaturation in the middle of the hyperapnea phase. So it looks different compared to an obstructive sleep apnea. Here is a comparison, between patients. This is a normal PAT signal with a sinus rhythm. And this is a PAT signal with the patient with atrial fibrillation. Yes, and here in atrial fibrillation, we don't see very nice a reciprocal pattern. We even don't see very nice the attenuation of the PAT all the time. But the algorithm detects the desaturations, yes, and in central also the central events over here. So the algorithm, based on this, places an apnea, hypopnea central event before the attenuation here of the PAT. Yeah, so there is not a real nice reciprocal pattern, but the attenuation of the PAT is there. You see some difference in amplitude in the PAT signal here and here. Yeah. How do we treat central sleep apnea? It depends on the patient. It depends on the amount of central events. It depends on how the central events look like. But most of the time they start with CPAP or some medication or ASV or whatever. And we also have, there is a phrenic nerve stimulator. It's also from Zolres Picardia, and the phrenic nerve stimulator actually paces the diaphragm, because in central sleep apnea, the patient is not breathing, and the phrenic nerve stimulator, the remedy, paces in the frequency that the patient is breathing. So the patient actually is when there is a central event, the patient starts breathing again. And it's still, there are still some studies going on, clinical studies going on, but it looks very promising for those patients. When we look at, so what I already told you, the interpretation of the report is very important. You can have different kind of reports. We show you some very typical examples, but you can also have this kind of reports where you think, okay, what's going on here? I see quite a lot of events. Then I see here the whole period of excluded periods. What's going on? There is some snoring. There looks like a lot of movements also. The oximetry is sometimes there are some, looks like there are some desaturations. Okay, this is the heart rate. It looks quite stable. And then suddenly you see a sudden increase of the heart rate with a lot of heart rate variability. What is this? Is it the patient who is waking up? Yes, or the patient is moving a lot, or the patient has, or it is an artifact. The probe gets out of, it's a bit out of the finger. Could be, yes. So when you see this, it's very important to check and to verify what's going on. Yes, because you want to know if this is really based on an artifact because the algorithm excluded it, yes, or there's something else going on. When we look in the raw data, we see that in the beginning, when the heart rhythm is stable, we see a very nice sinus rhythm, very stable sinus rhythm. And then when this change in heart rate starts, we can see a very irregular heart rate. And this patient is familiar with paroxysmal AFib. Yes. And when we look back in the report, we see that just before this period, we see a whole block of a lot of events scored by the algorithm. Yes. So it could be that this period of atrial fibrillation is triggered by a cluster of apnea events. Yes. So it's important to check and to verify what's going on, and to see if the breathing events are correlated to some arrhythmia, maybe already before the start of the atrial fibrillation. Yeah. So important, look at the report, do the interpretation, and zoom in if necessary. Yeah. Like I already mentioned, we have an FDA for automatic detection of atrial fibrillation. Flag it, not diagnose it, because we cannot, and we may not, and we don't want to, we can flag it in the report. And in the report, we can see here, we can see that in the pulse rate curve, we can see all those gray dots. Yes. And when we look here, we can see if there are parameter beats scored, or there are periods of atrial fibrillation. And here, for example, when we see this sudden increase in the heart rate, we can see that the algorithm detects a period of atrial fibrillation. Yes. So you can go into the raw data to check what's going on, but the algorithm already detected, okay, it starts already here. In the beginning of the night, there are actually quite a lot of parameter beats and some short periods of atrial fibrillation. Here is a period of paroxysmal atrial fibrillation. And actually, after this period, we can see there are much less arrhythmias, parameter beats, or periods of atrial fibrillation. It will be flagged in the report, suspected atrial fibrillation, total duration, and the longest event duration. And also it will detect parameter beats with the events per minute. So it's very helpful when we have it in the report. For now, you need to go into the raw data to check and to verify to see what's going on. And then we will have it in the report. So you will have your arrhythmia and your AFib in the report. How did we do that? Actually, what we did is we looked at, we did a watchpad simultaneous also with an ECG with an Holter. And there was a cardiologist afterwards detecting all the periods of atrial fibrillation and arrhythmias. Yes. And it correlated very nicely with our detection. So here we can see, this is a different patient, but we can see here in the respiratory movement, we can see the apnea events or hypopnea events, yes? And when we look in the PAT signal, actually, we see there is arrhythmia in the PAT, yes? So everything, the arrhythmia, looks like it's correlated, the short periods of arrhythmia is correlated to an apnea event, yes? And here it's detected by the automatic algorithm as AFib or parameter beats. So also in the ECG, detected by a cardiologist by each short 30 minutes, 10-minute window. And we can also see it here very nicely in the automatic detection and in the raw PAT signal, in the PPG signal. Yes, so we cannot, we have, actually we can see parameter beats. We cannot tell yet if it's more atrial oriented parameter beats or it's more from the ventricular, but we can see if it's parameter yes or no, and we can also see if it's related to atrial fibrillation or atrial flutter. Yeah. Again, the variability in the PAT signal, how it looks like, a normal PAT with a sinus rhythm and a PAT with when there is an atrial fibrillation. Yeah. In the Netherlands, we have like the sleep apnea management pathway for in patients with AFib. We have some sites who are doing screening patients with atrial fibrillation based on a virtual safari. So the patients all are all diagnosed and treated actually in an out clinic. So the patient there's no need for the patient to go to the hospital to receive a device, to do a sleep test, to bring it back to the hospital, to upload the data, and to come to the hospital again, to talk to the physician, to get treatment, etc., diagnosis and get treatment. This is all out of the hospital. The patient can stay at home. He sends the WatchPad 1 device is sent to the patient. The patient is doing a sleep test. The sleep test is be uploaded to the cloud. It goes to a virtual sleep center where somnologists, very well-known somnologists, look at the data, talk to the patient in a video contact, talk to the patient, so have also an anamnesia. They talk to the patient, look at the data, and see if the patient needs to be treated, yes or no, based on that data, or maybe in some cases, the patient still needs a polysomnography, for example, because they see other things. But this is a pathway where the patient can get diagnosis and treatment in a very easy and quick way. And it's important to diagnose patients with atrial fibrillation, because when patients with AFib have sleep apnea and you don't treat them well, you don't treat the sleep apnea, your clinical outcome of your ablation will also be worse, because there are several studies where we can see that patients with sleep apnea and who are not treated for the sleep apnea have a higher risk of recurrence of atrial fibrillation if you don't treat the sleep apnea. So it's important to detect, to screen, and to treat the patients. Okay, so again, report is very important. Yes, do the interpretation of the report. You can get a lot of information out of it. Yes, this is what I already discussed with you. There are also, we have developed some some scoring guidelines. And how do we do that? It's a COMPASS study. In the COMPASS study, we did a comparison with WatchPad simultaneous with polysomnography. Yes, and actually what we did, we looked at the WatchPad recording and we looked at the standard polysomnography, which was manually scored and reviewed by somno technologists. And the WatchPad, we did an automatic scoring. Yes, and we compared the results. Yes, and we thought, okay, how can we come closer to the gold standard, to the standard polysomnography? Because the WatchPad is already doing a good job. We have a very good correlation with the PSG, but how can we come closer, even closer to the gold standard? Can we develop some easy guidelines or some easy flowchart? Yes, and we did. So we have manual scoring guidelines, how to review data and how to look at WatchPad data and do manual editing, yes or no. Yeah. So what we detected is when you have a report and it's automatically scored, and when you have an ODI more than 20 per hour, an HI more than 20 per hour, and it all looks to you that everything is okay, there is an obstructive sleep apnea, and it's all, you know, the desaturation, the snoring, everything is there. There's no need to go into the raw data. Yeah. If you have a low ODI, you have a difference between an ODI and gap between ODI and RDI, or ODI and HI, and you have go in the raw data to check what's going on. Yes. Or when you have a high heart rate variability and a low ODI and a low HI, go see what's going on. Yeah. Or when you have a very high RDI, it means you have a lot of arousals, and a very low ODI and HI, go check what's going on. Yeah. So we have the rules in the manual scoring guidelines where you can see and check when you need to go into the raw data and when you need to verify the raw data. And it's very, very easy to do it. And in most of the time, I think in 10% of the cases, there's need to go into the raw data. In other cases, you can just rely on the algorithm because it's good. This is how the manual editing of the data goes, and don't go too deep in that because it's really the scoring of the data. So we need another training for that. We give trainings for that, how to score the data, how to look in specific cases, and how to follow these guidelines and follow this flow chart, because it's an easy flow chart, and when you have it in your mind, you can very easily, in up to 5 to 10 minutes, score a watchback test. I have a few more advanced cases. I have a few minutes left. So actually, it's nice when you look at the report, that's where we begin with, and we see this, for example. We can see this patient has a high heart rate variability and a very high also variability in the oxygen saturation. There are events scored by the algorithm, yes, but there's a very high heart rate variability, which means, okay, what's going on here? Is there maybe also, is there an arrhythmia? Is it all related to the events, or is there something else going on? Yes, the algorithm scores a high HI of 63%. Yes, the ODI is 4%, but this is ADHI is 3%. This is what we see in the raw data. So we see desaturations, and it looks like some central events, yes, but there's also some snoring, but also we see there are quite a lot of movements, yes. So what the doctor decided, to treat the patient with CPAP. And with CPAP, we can see this is with CPAP, this is without CPAP. So the oxygen saturation is more stable. There are less deeper desaturations, right? But there's still a high heart rate variability. There's more deep sleep. It looks like the sleep is a bit more stable with CPAP compared to non-CPAP, but still a high heart rate variability. Okay, when we look in the raw data, we see this. So we see that there are a lot of arousals. We can see the sympathetic activation here. We can see the PAT is going up and down. There is vasoconstriction. We can see it here in the heart rate. And when we go up, we can see that actually all those sudden increases in heart rate are related to movements on the actigraphy. So this patient this is very suspicious for PLM. Yes, there is a very stable oxygen saturation. Yes, but there is a high sympathetic activation, periodic. Yes, if we see this every 15 to 20 seconds, 15 to 30 seconds, and it's related to a movement on the actigraphy, it's very suspicious for PLM. Yes. What we did in this patient, is treated with also pregabalin, and this patient feels much better. CPAP, treatment for the PLM, but also sleep hygiene, because this patient had a very bad sleep hygiene, drank a lot of alcohol, and also had ADHD. So there were a lot of problems in this patient. But actually, to look at the data, look at the report, see the desaturations, you can treat the patient. The events, the apnea events are getting less, but still there is a lot of arousals. And when we look into the raw data, we see this. We can very easily see that those arousals are not correlated to a respiratory blockage of the upper airway. There's no respiratory issue, but there is an issue in the movements. So what we can see here, periodic movements on the actigraphy. Yeah. This one I skip because it's time. I saw. This is a nice one. This is I finished. I have 2 more cases very quickly. What we see here is a male, a man, 36 years old, BMI 32, has 2 watchpad tests. This is the first night where we see an HI of 50 and an ODI of 50. Yes. This is the second night. It's 1 week later, 35 and 35. What's going on here? Deeper desets over here. So the physician in this part, the physician asks, okay, this is, you have the first part of the night, okay, you're more in supine position, you have some deeper desets. Was there something different this night compared to normal, to other nights? And this was a reason. The patient had in this night, he drank alcohol, he had a party, and he did a sleep test with alcohol. Without alcohol, it's still a severe case, but here you can see very nice how the alcohol works out on the sleep apnea in the patient. Yes. So here you can show, this is very nice to show the patient what alcohol is doing on the sleep apnea with much more and deeper desaturations and a higher heart rate variability. Then we have another nice one where we can see very severe desaturations at the end of the night when the algorithm scored REM sleep over here, very deep desets, still 60%. And you think, okay, is this real or is this not real? What's going on? Let's go into raw data. Yeah, because in the other REM stages, there are no deep desaturations. When we look in the raw data, we see very long, severe desets. Yes? What's going on? These are apnea events or of over 2 minutes with very deep desaturations. Yes, 2.5 minutes. What's going on? Check, and you see this and you think, okay, this is strange. This is not normal. Is this REM sleep? What is the patient doing? It's only in the last REM period. What's going on? Go and ask the patient what's going on, because it's important to have the story of the patient also after a sleep test, because the patient was doing breathing exercises. Yes, in the morning with the watchpad, lying down with breathing exercises, you can get this kind of results. So it's important. Oh, sorry, here. It's important that what you measure, you need to relate it to the patient. So it's important to have the story of the patient. Yes, the watchpad is a home sleep apnea testing device. It measures apnea-hypopnea indices based on sympathetic activation and desaturations, calculated based on estimated total sleep time. And besides total sleep time, we have the REM and the non-REM stages, and we have the light sleep and we have the deep sleep. We can measure obstructive sleep apnea, central sleep apnea, Cheyne-Stokes respiration, positional-related sleep apnea, REM-related sleep apnea, and also flag arrhythmia and suggest periodic arousals. But you need to know what you are looking at. You need to know what kind of patients you have, and your anamnesis plus your diagnostic test is your diagnosis. Yes. So this was my story. I don't know if there are any questions. I'm a bit over time. There are questions in the chat. What is the indication to test for sleep apnea? What's the best way? The indication to test sleep apnea? Actually, most of the time, you can see it in the questionnaire. So the questionnaires are important, but the patient, mostly of the time, it appears it comes to a GP. I think I already discussed it in the beginning of the presentation. So the patient is feeling fatigued during daytime, falls asleep when he's watching television, sometimes falls asleep when he's driving, or when he's just in a conversation with somebody, or for the patient, it's normal to feel this way, but the partner of the patient hears that the patient stops breathing during the night. They are snoring during the night, but also different comorbidities like high blood pressure, diabetes, cardiovascular diseases. So a lot of comorbidities also related to sleep apnea. And then there is another question: what do you think of melatonin as a drug to help fall asleep? It can be helpful for some people with circadian rhythm disorders, but it's important also to diagnose, so to really test the melatonin level in these patients in a good way. So you need to have a diagnostic setting in a good way how you can test it, because it's very important that this patient stay, in a dark room, and that you need to do it in a proper way. Otherwise, it makes no sense. So you really need to test the melatonin level, and then you can treat the patients. Okay. Then what is the solution for insurance coverage in Dubai? Unfortunately, I don't know, because I don't live in Dubai. So maybe Russia can answer this question. And then there is another question. What is the most effective sleep treatment for patients with sleep disorder like insomnia? In the Netherlands, we use CBTI, so cognitive behavior therapy. We do it in a group with patients. Most of the time, there were like 4 to 6 patients together with insomnia. We have 6 sessions, so it's a group sessions, and the patients, they have like a workbook where they really need to learn how to sleep again, but also very important to give them advices on sleep hygiene, because most of the time we see that very easy things, very easy advices are really helpful for patients. So it's really important that they actually, in insomnia patients, we see that sleeping is such a thing that they cannot fall asleep anymore. And most of the time we speak from insomnia when a patient has 3 days a week bed sleeping over a period of more than 3 months. So it's really in a longer time we speak of insomnia. And these patients need to learn that sleep is a normal process, and they need to learn to sleep again. Sometimes CBTI is not enough, and you need to help them with some medication. Would be helpful. It depends on the patients, and it depends on the kind of insomnia. Here it says, okay, I've been in an in-lab PhD tech for 11 years. Only a few experience in home sleep apnea testing. What is, my question is, what's usually the minimum usage of for a patient to be on a portable polygraph, because we have to consider night-to-night variability. Yeah, there can be night-to-night variability, but you can measure for 1 night, you can measure for 2 nights, 3 nights, 5 nights, but what to do with that? So I think the most important thing, we are talking about night-to-night variability, and sometimes physicians really want more night screening. But at the end, they don't know what to do all the time with all the results. And there are specific patients who you want to screen multiple nights. But what we see with the watch bed, most of the time, 1 night is enough and covers everything. Yes, because you have the anamnesia, you have the clinical story of the patient, and you have the test. So if it's not conclusive, you can always choose to do another night. But sometimes when you are screening for nine nights or whatever, what are you looking at? So it's very, you also, what I told you in the beginning, each night is different. Each patient is different. So when you have 9 nights, what to do with it? Do you take the mean AHI, or you take the worst AHI, or the lowest AHI? So it's difficult. There are no rules for that. So we don't know, actually. And is it safe to use a cetirizine tablet for patients with insomnia? To be honest, I'm not I'm not treating the patients with medication, so I cannot answer this question. Sorry for that. I think there are no questions now. I want to thank you, everybody, for attending the webinar. If you need a watchpad test, it's in Dubai. The first cure is the one who is distributing our device, so you can contact them, and you can ask for a test to try and to see if you can use it in your sleep diagnostic department, yes or no. It's a very nice and easy way to diagnose patients, because patients can stay in their own home environment. It's a very minor points of contact, and it's giving a lot of information, and I hope I showed you this during my presentation. So you can contact the drugstore of the First Cure drugstore if you want to try the test. Thank you very much. If there are any questions, and if there are no questions, I think we can close the session. Thank you all. Have a great evening. And who knows, we see each other again. Bye-bye.